Thanks, guys. I will just run through a few slides about the South African response, mostly focused on the Western Cape, inevitably, because it's kind of hard to, with the volume of work here, it's hard to get too involved in the rest of the country. I'll try and give you an idea of what's been going on, just a little bit about South Africa, the size of it, 1.2 million square kilometers with a almost 60 million population, but quite sparsely spread, only 50 people per square kilometer. And it's a middle-income country, upper middle, but doing our best to become a lower middle-income country as far as I can tell right now. In terms of the health system, it's hard to get up-to-date stats. So the best I've got is from 2005. And thank you to Swasti Singh for putting these stats together for me. 2.8 beds per 100,000 population, just so you can see how that compares across Africa. And 9 doctors per 10,000 population, which is, I'm aware, is very high for the African context, even high for South Africa. Excuse me, the Western Cape is high for South Africa with about 17 compared to a national average of 9, but some provinces have as low as 3 per 10,000 population. And you can see the nursing and midwife number 13. Ideally, you'd want to have a number that's about double your doctor's number. So we struggle with nurses particularly. 4,000 ICU beds, but that, critical care beds, it does include high care, which is really just ward-based beds with monitoring. And it's spread between the public and private sector, and actually about 3/4 of those are in the private sector. And the issue in the private sector in terms of defining high care or ICU is that if you need more than just hotel services, you end up in high care or ICU. So the usage seems to be very high, but it's not really what most people would think of as critical care. And we have fairly robust EMS services across the country. That's just one indicator that over half of seriously injured patients are transported by ambulance, but all 9 provinces have got 30+ year history of EMS services, and they're pretty robust, particularly in the Western Cape. We run a 300 vehicle fleet, and the government is supported in Western Cape by 51 private ambulance services, between 1 and 20 ambulances each. And it's a similar sort of pattern across the country. In terms of where we are with our stats, as of the National Minister's last update, he brings out an update every late afternoon. You can see there that as of yesterday afternoon, we were just over, we broke the 300,000 barrier yesterday in terms of cases. We went up from 298,000 the day before. That puts us on worldometers, puts us 9th globally in terms of absolute value. But if you make that into more meaningful comparison, which is cases per million, we're 26th globally. And if you look at the deaths per million, we're 42nd. I should just say the case numbers, they really, it doesn't mean a lot. And I am happy to have any discussion with people about that, but it's entirely dependent on your testing strategy and the availability of tests in the country, and therefore inter-country comparisons become very, very difficult to do, even when you look at things like cases per head of population, cases per million. We have done 2.25 million tests now, and we found we've had 4,453 deaths. Gives us at the moment a 1.5% case fatality rate, which is low. The average, the global average is about 4.5% at the moment. And this is one of the things I'll come back to, that our epidemiologists and public health people are really struggling to understand what's going on here. And we have about a 13%, currently about 13% positive test rate, driven in large part by a very selective testing process, which I'll come back to. Okay, the country response, our first case was on the 8th of March in KwaZulu-Natal, and 2 days later in Western Cape. And on the 26th of March, we entered what has subsequently become known as level 5 lockdown, so a complete lockdown. There were police roadblocks all over the country. You could not move between any of the 9 provinces. You could not move between districts. So I live in the Winelands, but I work in the city, and there's roadblocks between the Winelands and the city on the major highways and major thoroughfares. 24-hour-a-day roadblocks. The only way you're allowed to be on the road is if you had a signed permit with your ID, and you had to have a justifiable reason to be on the road, which was essential service worker, or you're going a medical emergency or something like that. I've never seen roads that quiet in my life. Obviously, with my response vehicle, I was on the road all the time, but the roads were empty, and it stayed like that for 5 weeks. We had complete and utter shutdown, everything closed. The only things that were really going were health services and some government services, police, military. But it was a very, very aggressive lockdown. It was lauded by WHO as a really good response to control the spread, and also to allow health services time to plan. 2 things that are unusual, I think, compared to lockdowns across the rest of Africa. One is that cigarettes were banned and remain banned 120 days later. And I'm not entirely sure what the science is behind there, but and it's been one of the biggest complaints in the country. And for the 5 weeks, alcohol was banned as well. And as of Sunday this week, alcohol has been banned again. So we've re-entered prohibition for alcohol. So that's the main response. So by the end of that 5 week, government announced a 5-stage lockdown, with level 1 being basically open and level 5 being fully closed. So we moved at the end of the 5 weeks to level 4, which meant there were a few more people on the road, not really much more. And then we moved on the 1st of June to level 3, when alcohol became available again, and schools started to open slowly, and a lot of other businesses started to reopen. We are still at the point where most social activities are completely banned. So you can exercise outside, but you can't go on the beach. You can have a restaurant open, but you can't have more than 50 people. There can't be alcohol. There's now a curfew from 9 till 4, so you can't be out after 9. So if you do go to a restaurant, you'd have to leave about 8:30 to get back home. Casinos can be open with 50 people in. Minibus taxis can run as long as the windows are open. Things like that. There's a lot of very aggressive constraints on. And the reason we've gone back to a higher level of lockdown is that some provinces are really starting to spike in their cases now. Western Cape's been and done really with, and I'll show you that. Our activity is on the decline, but other provinces are really spiking, and so the government's taken a more aggressive lockdown stance. Second thing, we did a lot of the bulk of those 2.25 million tests come from community screening. We've screened about 25 million people. Obviously, some people get screened twice, but they deployed 30,000 community health workers who go knock door by door, either in a targeted approach or in a random approach, and screen people. And that generated about 1.5 million of those tests. We had a very testing policy at first, only done in health facilities, but in the Western Cape, we changed because the labs couldn't keep up, and partly because the lab capacity was maxed out, but a bigger factor was that we couldn't get the testing reagent from overseas. Some global leaders' policies were very nationalistic, and they wouldn't release testing reagent materials. So it was a struggle, as I'm sure most people on the call have experienced in their own countries. So we went from a very wide-ranging testing policy, where if you met the disease criteria, then you would be tested. We changed that to, in Cape Town, since 1st of June, we've only tested healthcare workers, vulnerable population, that's over 55, and a number of comorbidities, and admitted patients. So that's partly why the 80-something thousand patients that we see in Western Cape isn't that meaningful, because we know our numbers are much higher. We're just not testing people. We're only testing the ones who are admitted or vulnerable. We, again, Western Cape took a very aggressive stance on field hospitals very early. I'm actually coming to you from the convention centre. Those of you who've been to any of the conferences in Cape Town will know the convention centre. It's been repurposed into an 862-bed field hospital. We've admitted 1,118 patients over the 5 weeks so that it's been open. We currently have 200 in. At peak, we had 330. We've had 50 deaths. Tomorrow, we open a 340-bed hospital. MSF ran a 60-bed hospital. Each bed in our field hospitals has 15 litres of oxygen. Between the two big hospitals, there's 20 high-flow nasal oxygen beds as well. So we took a very, I was given carte blanche with these, and we took a very aggressive stance on creating extra beds because the Western Cape government recognised we would be about 1,500 beds short on the model if we took all the public and private sector beds that we thought we could get our hands on. So our field hospitals are going to be open for the next few months, but as I'll show you, they're probably going to be over-provided in terms of beds. So we took a lot of lessons from overseas, and we really drove home high-flow nasal oxygen as a treatment modality from the start. We've equipped all of our government hospitals with at least 2 high-flow beds. We tried as much as possible to stay away from intubation and use of ICU, although our 2 big academic hospitals' ICUs have been full the whole time. We haven't referred anyone to the private sector, 5 patients out of the total. But we really have avoided that by putting people on high flow, and they turn around very quickly, or they deteriorate, and then we move them to palliative care. We took WHO guidelines, we adapted them to a Western Cape specific setting, and then the rest of the country really have adopted those over time, both around primary care, emergency care, ward-based care, and intensive care, but also around triage for intensive care. So our Critical Care Society came up with a very robust screening tool, and if you don't meet the triage criteria, you will not get one of those ICU beds. And the South African government has a long-standing agreement with Cuba, so we took about 200 Cuban doctors, so we have 20 or so in Western Cape. We have some Cuban biotech engineers, and we have some epidemiologists, and they've been incredibly helpful in just supporting our workforce. In terms of our challenges, beyond the Western Cape, really, the health infrastructure is a real problem in the public sector in much of the country. BBC just ran a pretty hard-hitting piece yesterday on one of the provinces, and actually one of the better hospitals in that province, about lack of staff, poorly trained staff, inadequate PPE, doctors and nurses having to do the cleaning themselves, things like that. We do have a lot of challenges for sure across the country, which makes the national response very difficult and very different to the Western Cape response. Like everywhere globally, we've struggled with PPE, and partly through supply and partly through, we have very strong unions here, and they do a very good job of motivating for their staff. But in this instance, often what they've asked for ends up with the staff wearing more PPE, and then there's more things to take off. And actually that puts you at a higher risk. The PPE that you need to be safe, that is CDC or WHO compliant, is less than most of our hospital staff are wearing, because the unions somehow have got the message that more is better. And so we see people being at risk unnecessarily. And that ties into we really haven't had much of a problem in Western Cape. We've had 1 or 2 EMS bases that have gone on a very temporary strike. We've had 1 or 2 hospitals where the nurses have gone out for a few hours, because we've taken a very proactive position on trying to communicate to staff about their safety. But across the rest of the country, we see staff strikes all the time. probably one of the biggest challenges, the economic effects of lockdown. Like every other country, we've been absolutely hammered by this, but the tourism industry drives about half of the Western Cape's gross domestic product, and it's completely closed for months now and will take years to recover. And we think we've created about, just in the Western Cape, about 2 million people now more unemployed than there were before, and our unemployment level was already in the high 20% level. Clinicians have dealt with a lot of uncertainty around changing guidelines all the time, particularly. We've had, Western Cape has 4,500 positive staff members in total. So about 15% of our staff workforce has become positive. Higher percentages in other parts of the country. Mental health has been a really big issue and something that we've been trying to tackle as proactively as possible, again, in Cape Town. I'm not sure the rest of the country's really done a great job on this, but we've really tried to focus on staff wellness and staff well-being and staff getting appropriate time off and being able to express their concerns in a non-judgmental and safe space. And then, like most people, we've had to redeploy finally medical students or surgeons or dermatologists and so on, and put them into these COVID areas and upskill them on things like swabbing and taking a history and all the things that a large chunk of our workforce don't do on a regular basis. And then the separation that I'm sure so many of you struggle with, the separation of work life and home life, so keeping your loved ones safe at home. So what do you do when you get home? So we have a lot of our staff who have their work clothes and their home clothes, and they sort of get naked at the front door and put all their clothes in a plastic bag and throw them straight in the laundry, and they step in and go straight into the shower, and then still are not having that much physical contact with their families, and that contributes to the burnout and obviously the stress as well. And I'm not going to talk about this, but this insane that suddenly we did away with peer review and everything's pre-published, and it is this, no, it isn't, yet it is, no, it isn't. It's crazy. So my last slide, just where are we going with this? I'm just showing you what the total cases are looking like in the country. That is driven by 2 provinces. Gauteng is the biggest province, about 18 million, and they say that their hospital beds are full. They don't really have a field hospital plan. They don't really have an extra clinical staff plan. They do have a lot of strikes and a lot of problems with their existing infrastructure. And Eastern Cape as well is driving a lot of those numbers. Western Cape still has the highest per population number, but this is, I'm just showing you one graph from multiple that I could show you. So the black line, the big black line, is our remodeled hospital admissions. So this is not cases or deaths, this is hospital admissions. So we had a projected model that gave us a peak at the end of June of about 5,000 hospital beds in total. This one that you see now was remodeled with data until mid-May and gave us a peak at the end of July of about 5,500 hospital beds. We have 4,000 in the province, so we built another 1,500 in these field hospitals. The bottom grey line is the modelled ICU bed component of that. What you see, the different colours don't really matter that much, but you see in yellow and red are ICU admissions, green and grey are hospital bed admissions. And you'll see that we probably peaked in the last week of June in Western Cape. The city is on a much steeper decline than the rural areas. Rural areas are still increasing, but the 6 million population is split about 4.5 million in the city and 1.5 in rural. So even a steep rise there is going to be hard to drive that graph up. So our epidemiologists and our health leadership don't know what's going on with that and why it's like that, or what we've done and why the case fatality rate is 1.5%. Probably we have a younger population than many models had to be modeled, we had to model on overseas work where the population's older, so that is some way protective, but we certainly have a very high rate of comorbidities. 50% of our deaths are diabetics. We know our HIV mortality rate is about twice that in the HIV negative population. So we should really have a higher impact of this, but we seem to have a very low impact and we have no idea why. So watch this space. It may be in a month's time, I'm telling you a very different picture. Okay, thanks, Rory.
Thanks so much, Professor Wallis. I mean, I personally have a lot of questions that I'll probably just shoot you over at some point, but we really appreciate you joining us as a presenter, especially considering all of the work that you're doing in Western Cape and beyond. Great, thank you so much. And we now have another question from Sarah Ashley. And it looks like you should be able to unmute yourself, Sarah, if you want to ask your question.
I was just curious for both Dr. Muragizi and Dr. Wallis, if you feel like you've been seeing more mortality from non-COVID conditions, just secondary to all of the barriers and the fear for the lockdown related to COVID. I feel like here in Kenya, I don't have the numbers to show it, but I feel like our mortality is really high from non-COVID. So I'd be curious if that's the same there and how you might have addressed that.
Yeah, as we said, the mortality is not high in our country. Maybe it's due to the government measurements of to combat against COVID-19 in our country. The patient came early. From community, they came early, and the government provided everything for patients. They don't have to think about food or other things. And our population is younger. And the one who we received in our treatment center were younger and we are stronger, and we also the government introduced this measurement to avoid the direct contact with the patient, and then we reduced the contamination rate, and then we are able to manage some cases we have of COVID-19.
Sarah, I think your question, I see from reading your questions about non-COVID. So the Medical Research Council here track mortality very closely, and they say it's a bit early in the rest of the country really, but certainly from Western Cape, we've had excess deaths compared to this time last year and the year before due to COVID, but we've had a reduction in deaths from other causes. One of the things that we're all scratching our heads about is where's all the TB gone? Not a newly diagnosed TB, we know we're missing, and we'll pay for that price later, but the TB admissions have gone, the strokes have gone, the heart attacks have gone, and we are not picking up excess deaths in the community, so we're not entirely sure what's going on there. But one of the big things that kept our overall mortality rate down is alcohol ban. Our trauma emptied, our emergency units emptied, and on 1st of June when they reopened, the emergency unit attendance went up by 204%, including COVID and non-COVID. Like last weekend in Kailicha Hospital alone, they had 96 alcohol-related traumas, of which 36 were full resuscitations. So when you take that away from, about 40% of our normal work is trauma, when you take that away, you lose a lot of our regular deaths. So it's a sort of mixed message. We know why some of the deaths have gone down. We don't know why the sort of medical causes have gone down, but maybe just people staying at home and taking less risk and less exertion, being out less. But overall, increase in deaths, but it's all COVID related.
Thanks.
And Prof, while I have you, we have another question from Eric Zogo for you, which is, and unfortunately he's not able to use his audio, but the question is, what is your opinion on the current lockdown level in South Africa? Will you advise different lockdown levels in the country as per the rate of infection?
Yeah, it's a tough question, and it's in some way economical rather than just health. From my personal perspective, I have a whole tourism business. I employ 40-something people. I will probably lose my farm from this. We have had to lay off all of those people, apart from 2. So I see firsthand the effects of those. That's now 40 families have no food on the table, have no income, have no prospect of it. The government provided support until the end of July, but that went away with a view to them, I think, expecting that they would be able to open up the economy again. On the flip side, the things like having alcohol, while it allows jobs and money in the economy, it causes deaths and it creates chaos in the health system and overstretches the health system. And Western Cape could probably afford that right now because our COVID's right down, but the rest of the country where the COVID numbers are going really high, particularly in 2 or 3 provinces, they cannot afford to have any other patients in the hospitals as much as possible. Apart from those who really have to be there. So I think it's a very mixed thing. I would like to see some more sensible. I think the government's been held a little bit hostage by the taxi industry, for instance. So the taxi regulations do not align at all with the rest of them. You're allowed to have a full taxi as long as the windows are open, but everything else is 50% occupancy for all other transport. So that really speaks of bullying by the taxi industry and not sensible regulation. I think there's some other things like that that are a bit crazy. I'd like to see a bit more sense in some of the regulation. And I would like to see a graded regulation where parts of the country that are at lower levels of cases could be more open. But I'm not sure we have the nuance to do that well or the resources to regulate it well.
Thank you, Prof. We don't have any other questions coming through at the moment. However, if anyone does have questions as they continue to sort of debrief this information, you can feel free to email us or refer to our website, afem.africa, where there are a bunch of different resources that you can look to. This is the conclusion of our webinar, seeing that we have reached our 10-minute mark. And I just want to thank everyone for attending and for being such engaging attendees and participants. And then a huge thank you to both of our presenters, Dr. Muragizi and Dr. Wallis. I know how full both of your plates are, and we're so grateful and privileged to have you both speak with us today.